We've got a system at the moment where there's long waiting lists, there's not much money, everyone's feeling the pinch, and we need to think of ways in which people can see the right people, so patients can see the right clinician and get the right care. And I think SEM is in a really great, strong position to be innovative in that space. Patients like to see specialists, and SEM doctors are specialists in musculoskeletal care. Often you find if you speak to patients, they get frustrated by going through a very long journey before they can see the right person. SEM doctors are in a very good position in that they can be embedded within teams where they can really impact patients at the right point in their journey.
Sport and exercise medicine is a very, very broad church, and I think perhaps the sport part of it is a little bit misleading, because sport is really a very small part of what we do. So we not only look at musculoskeletal injuries, which is any injury to joints, muscles, tendons, bones that don't need surgery, but it can also be exercise interventions in people with cancer, people who have got diabetes. I see SEM as very much a horizontal speciality. So instead of just going in with an exercise medicine problem and then working through it till you come out the top, I see it as operating across the whole broad spectrum of all the other hospital specialities.
We work really in tandem with physiotherapists and other allied health professionals, and it's really helpful to have someone like that who's able to see the varying facets of MSK so we can develop these services. That's the real selling point of sports and exercise medicine. We're not just one small specialty, we're many specialties built into one.
SEM consultants are best working in multidisciplinary teams, not just with advanced physiotherapists, but also with nutritionists, strength and conditioning doctors, psychologists, physiologists, etc. I mean, we work well as a multidisciplinary team. I see SEM doctors as part of that team.
I think one of the perceptions that the public or other doctors may have, that SEM consultants are only working in Premier League football or Premier League rugby or whatever it is, but actually they have a real important role, and their base actually is in NHS care. We have obviously national centres up and down the country. SEM consultants work out of there, and I think it's really, really important that they're seen as not just team doctors for the world's greatest athletes, but actually they're there for the public as well. And some of the good things about them actually is they take some of that high performance medicine that they learn working in those environments and then translate it to everyday patients like you and I.
The key way that I approach my conversations with patients is really approach with a what matters to me approach. And the sports and exercise medicine model of training and delivery is around really giving personalised care to patients. That allows them to not have to tell their story several, even kind of over 10 times to patients, because you can really, in one consultation, start to really understand what matters to them and use your behaviour change skills and your influence in the system to allow people to move forward with making their behaviours and choices more healthy.
Sports and exercise medicine team really complement the whole of the orthopaedic and musculoskeletal service. They just complement how you deliver care to patients with a more holistic approach, and we learn from each other. And I think that's really important. And actually not everything requires surgery or an intervention. It requires more conservative measures for treatment of patients.
Sport and exercise medicine consultants and the teams associated with them are vital to support the NHS in a variety of ways, but they particularly complement the services in orthopaedics and rheumatology, physiotherapy and other types of musculoskeletal services. And that's because they offer a particular type of expertise and are used to working very closely with other team members to get an effect which is really important for them.
I think you need to go back to the start and look at services were run largely by physiotherapists in community for MSK, and the The addition of sports and exercise medicine consultants and other health professionals provides a multidisciplinary team approach, which I think is really important. The SEM consultant role in that is clearly seeing patients and offering the advanced skills they can provide. But I think also leadership and management of the multidisciplinary team is an important part of how SEM consultants should work in MSK services. And I think the other members of the multidisciplinary team benefit from having that SEM consultant who's a doctor with a very broad view of health services, both in terms of providing clinical services, but how the services interrelate.
The existing workforce is quite reactive. It reacts to pathology and disease, and it sometimes reacts in possibly inappropriate ways. So there is a big focus on waiting lists for surgery, but what we know is that many sports and exercise problems don't need surgery, and if they can be managed appropriately at an earlier point, you can ease the strain on the rest of the acute hospital, both in waiting lists and inpatient stays. So yeah, it has a key role in helping the rest of the NHS through population health and supporting people who are fit and active and exercising. It's recognised that they can bring a benefit and something additional to what we have in the NHS so far. And so it's entirely appropriate that sports and exercise medicine is a specialty within the NHS. What needs to happen now is it needs to be utilised properly across the country.
We know that exercise is the best preventative and the best treatment for long-term conditions and chronic disease. Everything from mental health to cancer to metabolic health. And SEM consultants are best placed to be able to lead on that and understand how to manage physical activity in patients with chronic disease.
Employing consultants in sports and exercise medicine in NHS clinics absolutely meets the NHS kind of plan for the future because of the impact that getting people moving in a safe way has on long-term health. This is something that I do in my own practice anyway at the moment in the Ministry of Defence. So it's about using exercise as a long-term strategy for health. I look after lots of people that are both in their 20s and 30s, but I also look after people who've become more sedentary as they've gone into staff roles. And it's about how do we get these people away from the cardiometabolic kind of risk of becoming more sedentary, losing lean body mass, putting on non-lean body mass, and allowing them to exercise in a way that then has implications for their health is absolutely huge. Lots of those things can be changed by patients having the right education and also the right support to allow them to move. And this then prevents them from getting osteoarthritis, osteoporosis, cardiovascular disease, diabetes.
Rehab is a really important part of improving patients' care. So when you've got a patient in the inpatient setting, their rehab is key to actually optimising their care and improvement. So for example, neuro rehab, for example, we don't see enough of that on the wards, and actually patients need proper rehab to improve their actual outcome. And that comes from some of the sports and medicine guys. It's just really good to work in teams where you've got the orthopaedic surgeons, the surgical side of things, and the sports and medicine team, the medical side, with physiotherapists, for example, and also with podiatrists and with the radiologists to give the best patient care.
Sports and exercise medicine, by the very nature of the training that we do, looks at the multidisciplinary team approach, and we're quite used to being put into leadership roles of a multidisciplinary team, and that's something that I don't think you see as much in other specialties. We can provide help with, as I said, starting off the rehab process, and we can do that within the clinic setting. Actually, patients start to get better if we're giving them the right stuff already. Now, that potentially could reduce the amount of touch points they need down the system, i.e. maybe less in the way of rehab that's needed when we're referring on, maybe less in the way of investigations needed as well, compared to
a sort of clinic where maybe they're seeing more numbers, they don't have the time available to do that, and therefore they might be using more resource down the line. We feel that we could make pathways more efficient, and we're used to working within different disciplines and understanding what they can bring to the table in order for us to make sure that the patients are getting the right care at the right time.
What are the unmet needs in patient care that exercise medicine can address? Wow. I mean, it's huge. I think it's a completely untapped resource. As I said, in the prevention space, in the treatment space without requiring operation, within the well-being and general physical activity space, there's so much more that we could do if we had the resources and the manpower to do it. It's a huge unmet need, which would make a massive impact on the health of the nation.
When it comes to the government and the NHS long-term plan, I think this is a really exciting time for SEM, because the long-term plan is to essentially move care away from secondary care into the community, and that's where SEM can really make a big difference. For patients, seeing the right clinician as quickly as possible in the right care setting, but also having those good set of skills is a great opportunity for SEM to think innovatively in how it can really help patients and the government realise their aims so that they see the right person in the right place. I think that the government plan of changing the model of how we look at the healthcare can really help SEM, and it requires kind of high-level thinkers and strategists within SEM to really think about how they can implement that.
I thoroughly believe that rehabilitation is a force for economic growth, and SEM can really contribute in terms of improving return to work and improving the outcomes of patients, because we understand the principles of rehabilitation and we understand how to work with other members and professionals in the sector, such as our physiotherapy colleagues.
Obviously, it's much cheaper to treat things before they happen than it is once they've happened. And we know that across a whole spectrum of diseases, heart disease, cancer, bowel disease, mental health, that being physically active is really important. And exercise medicine deals with all those areas. It can encourage people to be more active, give them pathways of how to become more active, and encourage them to remain active. I've done some research with children in primary schools, which has shown that if we can get them just a little less sedentary, not even trying to get them more active, but just a little less sedentary, we can reduce their levels of obesity markedly, whereas normally they'd go up. The schools that we're intervening in, the levels of obesity are going down. And that's just a small example of the sort of things that we can do within the space of health.
I firmly believe that physical activity should be in all policies and clinical pathways. I think as sports and exercise medicine doctors, we're able to lobby and advocate for that. This means that every ICB around the country should be looking at having sports and exercise medicine firmly within the core of its staff to help really embed it into all the discussions that are being had about delivering health inequalities.
So one of my roles is the National Sport and Exercise Medicine Doctor for Connect Health, who are the largest community musculoskeletal provider. One of the things I've done is introduce the SEM model as part of a wider multidisciplinary model within community musculoskeletal medicine. That's something that we've done nationally. Our pilot project for that was Northwest Musculoskeletal Services, so in Manchester. And what we have now is we've had 4 consultants through that service. We've had probably about 6 registrars trained through the service, and they work alongside the wider multidisciplinary team of physios and osteopaths and podiatrists. So that model's been going for quite a few years now. It works because it utilises the right skill set of the different clinicians that are there, and that's something that we have now started emulating in different services across Connect nationally. and it helps create permanent substantive SEM consultant posts. It helps train registrars, because ultimately registrars, part of their training needs to be focused on community musculoskeletal medicine, and that model ticks those boxes as well as complementing the service and helping patients.
So our experience in Nottingham was we already had an adult service set up and going under Professor Mark Batt back in the late 1990s. Based on the sheer volume of referrals they were getting and the wait lists in elective orthopaedics through adults, that's how the service was born, and then that morphed into the paediatric service as well by taking patients off their wait list that had obvious soft tissue injuries and didn't look like they would need a surgical pathway, and that's how our service started. So we looked at the fact that there was a need, i.e. a long wait list, and that wasn't going to be coming down sooner. And then looking at the benefits of why would we be different to an orthopaedic surgeon, well, one of the answers was not everyone on the list in the paediatric service needed a surgical pathway. So why would you need a surgeon? Why not use a sports and exercise medicine consultant?
The model which I'd refer to is our model in Northumbria, where we work in partnership directly with Northumbria Healthcare Trust, which is a secondary care and tertiary care hospital trust. And they have valued our expertise working in the community because we can work to make sure that the pathway for patients into secondary care is an efficient one, because no one wants patients going into secondary care that shouldn't be there. So we work in the community care with trust staff, so we're mixed together, and we have our targets and performance indicators, and we make sure that patients who flow into hospital need to be there. And the feedback we get from orthopaedic surgeons is they're now seeing the sorts of patients in outpatients they need to see, and the conversion rate to surgery is very high. And because we're in that partnership, the service is managed over both organisations, so we make sure that patient pathway flow from primary through community to secondary care is as efficient as it could be. And I think that's where everyone needs to get to, integrated partnership work across the whole patient pathway.